I'd just like to welcome everybody to the third session of the Hidden Epidemics and Epidemiological Obfuscation Research Network. Today, we will hear from Dr. Hilary Ash, a rhetorician and visiting lecturer at the University of Pittsburgh. Dr. Ash's research, focuses on historical instances of medical injustices. So particularly those that have profoundly affected women and people with disabilities in the US. In 2017, she received an award from the National Communication Association for her work on the 1927 Supreme Court case, Buck versus Bell, which legalized the forced sterilization of disabled people in the US. Her most recent publication is an analysis of the figure of the public woman in World War II venereal disease campaigns. Today's talk, however, is from a larger project about AIDS and women. I could say more about this project, and if you joined us a little earlier, you probably already heard me rambling on about it, but I think maybe it's best if I just let Dr. Ash take over now, and then I'll throw all the rest of the questions, including about her upcoming publication on case definitions, into the discussion. So without more to do, Dr. Ash.
Thank you so much, Freya, for that lovely introduction. I wanted to start this talk today specifically talking about how I came about this project and why it's so relevant, why we need to care about it. So about a decade ago, I was, in my early 20s, looking at master's programs and sort of newly discovering my queer or bisexual identity. And I started learning about queer history, gay history. Part of that was discovering the AIDS crisis anew. So I was born in the late 1980s and lived in a pretty conservative, Reagan-loving family. And so we didn't really talk about HIV/AIDS. And so it was really something to come to this sort of knowledge in my early 20s. This led me to wonder what my own risk was as a woman who had had female partners. And I sought out that information. I found basically nothing online. In terms of safe sex practices for women who have sex with women, the recommendations, no lie, in 2011 included saran wrap or cling film as a good prophylactic for oral sex. And the other various prophylactics suggested on this government website weren't really that much better. So this lack of knowledge around sexual practices between women and STD risk led me to pursue this in an academic vein. And for years, I pursued this doggedly. And I talked with bioethicists and I asked, or rather wanted to talk about, whether or not lesbians could get AIDS. And the response from this bioethicist was, well, of course they can. But that is overlooking a lot of really complicated history, for instance. So I talked to a public health official. I wanted to do a project on women and AIDS or lesbian and AIDS. And he said, that's just not something we look at anymore. Like, it's been decided, we dealt with that in the late 1980s. This didn't satisfy me either, because in doing my research, I found that the data wasn't there. There were all of these claims that somehow women who had sex with women couldn't get HIV/AIDS from sort of any types of same-sex sexual contact, right? And maybe in rare cases, but there isn't a lot of data out there. So from this, I sort of pursued this dissertation project. I found that there wasn't enough data out there to even do a full project on women who have sex with women before addressing this larger question of women in general, which is how I sort of got to this point. But I'm not the only person, unsurprisingly, who has thought about this question of risk for women who have sex with women. And so what I'm going to show you here on this slide is some excerpts from the radical feminist publication Off Our Backs. This was published in late 1991, early 1992. You can see on the leftmost image, Does Lesbian Sex Transmit AIDS Get Real? That was published by, written by a woman named Beth Elliott. And she claims in this article that female AIDS activists were motivated by sexism and wanted to tighten the ties between AIDS and homosexuality by claiming lesbian risk. So she was very much against any sort of discourse or conversation happening around lesbians and AIDS risk. In January or February in 1992, you will see this smaller column here in the center, does lesbian sex transmit AIDS? View irresponsible? A woman named Libby Smith responded in an op-ed to this initial article by Beth Elliott. And Elliott says that, or Smith, sorry, says that Elliott in the initial op-ed ignored the fact that, quote, lesbian sexuality may involve blood, menstrual or otherwise, or anal penetration, both of which are more likely to transmit the virus. Smith is speaking from experience. She was a substance abuse counselor and AIDS researcher, and she found that AIDS in her facility, research on AIDS in her facility, did not treat lesbians equally to other, gay men, to other women, what have you. So, for instance, at her facility, a research questionnaire was designed so that, quote, any woman who has not had sex with a man in the last 5 years will skip to the end of the survey and not answer any question about her sexual behaviors. This is absolutely in line with what the CDC was doing with their own case report form. But this is a sort of separate research study that Smith was working on. She also saw this dismissal of sex between women as examples of the old what can two women do in bed question, right? And we'll find that, especially as we dig into classification schemes in a minute here, this question of, what do women do in bed? How are they culturally perceived to act in a sexual way has influenced the way that data is collected. And so women are seen as passive sexual partners, they're receptive sexual partners, this sort of whole, close your eyes and think of England sort of approach to sex, right? You're just kind of supposed to lay there and receive it. And so this problem is then exacerbated when we talk about women who have sex with women. So I want to pick up this thread that Smith introduces about data collection. And today I want to talk to you about a couple of things. First, I want to talk about classification. So I'm not going to bog you down with too much theory, but I want you to understand how the classifications we use in everyday life are actually contributing to a particular way that we view the world as a society or individual cultures. After that, I want to talk a little bit about the AIDS sort of surveillance project in the United States. What did data collection look like? And address some problems that you will probably see in any activist literature on AIDS in women. See these problems that AIDS activists address. And then finally, I'm going to show you my findings from this particular thread of the project and get to show you some primary source documents that I think will be really disheartening, but also fascinating. So, classification as a thing that we do, right, it renders new things in the world understandable. And it does this by establishing similarities and differences to things we already know or understand, right? So we have certain rules and we have to decide where this new thing will fit. So if we think about a new species being introduced, say a new fish, in what fish family does this new fish belong, okay? So this starts to get a little sticky because when we say this is similar to X and dissimilar to Y, we're forming a relationship between this new thing and things that we already know a lot about, and we know how to interact with these already existing things, right? And so once that thing, this new thing in the world is labeled similar to X, we then know how to interact with it politically, socially, and ethically. All right, I'm going to show an example of this in a minute. So when we need to establish whether something is similar or different than already existing things, we have to strip away any nuance to a certain degree, right? So in this process of stripping away nuance, whether that is a sort of severe stripping or just minor, some data is going to be lost. That is just the nature of the beast that is classification, right? Once we've established a classification, these systems of classification tend to become invisible, except when they conflict with one's positionality in the world. So for instance, many of us probably don't think much about ticking the box that says male or female, right? But if you are intersex, if you are trans, this box becomes a much more complex box to tick, right? So that is one of the ways in which visibility becomes heightened, but it doesn't become heightened for everyone. And we have to bring attention to these sort of discrepancies and reveal that actually this is sort of an arbitrary classification that we've made that has become standard. So classification systems then produce knowledge and they replicate a culture's master narrative, right? And this is what I mean by this. So this is an example of the US Census and racial categories included on the US Census from 1790 to the year 2000. One is particularly important here when we're talking about master narratives is the development of, where this arrow is pointing here, the post-Civil War era. We're getting into Reconstruction, and suddenly we see that we now have classifications that for sort of anyone who is Black, they can be classified as Black, mulatto, quadroon, right? So 1/4 of their ancestry is Black, or octoroon, 1/8 of their ancestry is Black, right? So what this communicates to the population, what this reinforces, is that no matter how many white people you have in your ancestry, right? One Black person in your ancestry makes you Black, right? That's a master narrative. It's this one-drop rule that becomes codified in the way we take data about the people in this country, right? Or in my country, right? And then we can also see that very early on, race was less about like racial or ethnic identity and had really close ties to the economic position, right? You were a free white female or male, or you were a slave, right? Blackness and slavery was synonymous, right? So this is an example of classification reinforcing social beliefs, right? And then we see it actually, we get rid of some of these terms as we move forward. So when we determine what category you fit in, suddenly we know how a subject can be treated what kind of rewards or punishments might be fitting as a result of their social position, and all of these other things. So to be classified as an octoroon in 1890 was to tell everyone in your community, how they could behave towards you. So this gets us into this broader question of how is classification persuasive? And this is kind of the one theoretical takeaway that I want you to have today. When we strip away nuance in order to make classification happen in the first place, the creator of this classification selects and deflects portions of reality. So if I were classifying objects in a kitchen by color, right, that is going to result in a different set of classifications than if I classified by toxicity, right? So if I'm choosing color, then I'm stripping away any sort of sense of risk or danger with these items in my kitchen, right? Selection and deflection, they're not bad, right? We have to do it. But it is an ethical choice, and that's important. So whoever is creating our classification system, their bias is going to be inherent in how the classifications are created, right? And so they're saying these parts of reality are those we need to emphasize, right? Racial heritage is important to us as a society, and therefore this is what we're choosing to highlight, right? And we'll see more examples of this later on in the AIDS-specific content. Also, classifications and standards are context-bound, right? They're set in a historical moment, and so they inherit the social and cultural values of their time. We no longer use terms like quadroon, octoroon, obviously, but they are still part of the history of census classifications. There are still implications of their inclusion in the 1890s that carries through to today. They become more entrenched, these biases, and we tend to not see these values because data is seen as self-evident, or according to Lisa Gittleman, the fundamental stuff of truth itself, right? So data holds a really special social place for us in the world. And this project is calling into question the sort of objectivity of data. So the next section that I'm going to talk us through is the sort of nature of surveillance in the US. And some of this stuff might actually surprise you. So the US actually has no central authority for disease reporting, right? The CDC is not a central authority. In fact, states, territories, and independent local authorities legislate what diseases are reportable. And so these vary across this entire country, which is maybe not immediately clear, but will become more apparent as we talk about HIV reporting, specifically. So at the beginning of the AIDS epidemic, state and local public health officials implemented disease surveillance according to the traditional procedures. There was designated public health reports that I'm going to show you that were filled out. And these include things like patient identifiers, demographics, risk factors for transmission, etc. These reports were then de-identified, and this varied according to state how this was done, and then sent to the CDC for national surveillance. And we'll see some of the documents and the results of that reporting in the next, in the findings section. So because AIDS was discovered before HIV, AIDS surveillance existed prior to HIV surveillance. And HIV surveillance was far more controversial. So HIV positive people were concerned about stigmatization and job loss due to HIV surveillance because there was no cure for HIV, it became AIDS. And so it was sort of enmeshed in this culture of stigma. So in response to this, some states use codes instead of names to report HIV cases. However, the CDC was concerned about duplicating these de-identified cases and this sort of potential inaccuracy. And so the CDC would reject any de-identified case report forms for HIV surveillance, right? So we have a really incomplete picture of HIV in those states that choose to de-identify. In the US, it was not until 2008 that all 50 states and territories had implemented confidential name-based reporting, finally allowing the CDC to track national HIV morbidity and mortality rates. So these were tracked separately all throughout this time. And the problem with the accuracy of this surveillance data is that in the US, we have historically and continue to use HIV surveillance data to determine things like funding and services for people with HIV. So this is through programs like the Ryan White HIV/AIDS program, other sort of federal programs like this. So the accuracy of the data really matters. And activists knew that these things mattered, right? So there are 4 primary concerns that activists had, particularly regarding women. So they saw that women were not being included. And their first concern was about the morbidity and mortality statistics themselves. So because the CDC separated AIDS cases by risk behavior categories, which I'll show you an example of in a minute, AIDS rates in women appeared to be statistically small in number. So initially in the early 1980s, AIDS symptoms in women were not researched because the number of cases in women in the surveillance reporting was considered too small for quantitative analysis. In the mid-1980s, when the number of AIDS cases in women matched the number of cases in men at the start of the epidemic, public health officials then claimed that the percentage of women as a function of the total cases was too low. And this justified a lack of research when other populations had higher rates. So you can see in this weekly surveillance report from December 31st, 1984, that the rates for females under patient groups are significantly lower than those in males. And so this was used to justify the lack of research. And this ties into the AIDS case definition too. So it's a systemic problem. The second issue is that there was a hierarchy of transmission that the CDC used to collect data. So in the early 1980s, the CDC did not allow for an AIDS case to have multiple means of exposure. So you can see this example from 1988 of all the risk factor combinations that the CDC would eventually come up with. Men who have sex with men, sometimes coded as homosexual or bisexual men, was always at the top of the hierarchy. And you can see that here at the very top, right under AIDS cases reported to have a single risk factor. When multiple exposure risks was introduced in the late 1980s, which we can see here, men who have sex with men as a definitive exposure route dropped by 50%. So men who had sex with men, after multiple exposure or multiple, means of getting HIV, once that was introduced, we see a dramatic drop to 50% from, 80%, 75% previous years. So we have an artificial inflation up through the the late 1980s of AIDS rates in gay men. All right. So if you were say in 1983, you were an intravenous drug user and you were a homosexual or bisexual man, you just went into the homosexual or bisexual man category, and that was it. So we're already seeing the nature of the hierarchy itself causing problems with the data. So the only category that women could fall into early on was intravenous drug user, right? And had we, or the sort of first category that they could fall into was intravenous drug use. Had the CDC privileged intravenous drug use first, and thus sort of having a rate of dropping that rate of homosexual or bisexual cases, male cases, we may have an entirely different perception of HIV in the US, because that initial first risk category would have been sex inclusive. The problem, so the second problem with the introduction of multiple risk factors, which you can see on the sort of bottom half of this illustration here, is that women could never have, very early on, they could never have multiple risk factors. And so we only see things like homosexual or bi male. We never see any sort of consideration for female specific risk categories. They could fall into some of these other categories later on, but it was never made explicit. And so that was another challenge for women specific data. Okay. And finally, women more frequently appeared in catch-all categories, such as undetermined mode of exposure or no identified risk or simply other, because men's visibility was privileged. So we'll see more examples of that later. The third of four concerns was that of risk categories, which I've kind of addressed a little bit, and I want to add on to that now. So the CDC mostly defined women's risk according to their relationship with others rather than autonomous people. So they were always partners of drug users, sexual partners of homosexual or bisexual men, mothers of pediatric AIDS patients. This erases women as women from large parts of the data. So this also didn't work quite the same way for gay men. So because gay men were viewed as promiscuous, and that was the reason why they, contracted AIDS, they were never seen as partners of, even if they were sort of the receptive partner in the sex act, right? So gay men were seen as individuals with agency, even if that agency was, socially apprehensive, to a large majority of the United States at the time. So it was stigmatized, but they were still allowed to have agency in ways that women were not. And you can see on this diagram here, the rather lengthy list of sex with, born in, sex with. This also makes it so women's risk becomes decontextualized. So her risk is either a result of a partnership with a vast, ill-defined public out there, or her body was viewed as ground zero for sexual danger in instances of sex work, right? And sex work isn't something that's introduced until the early 90s into consideration, or late 80s. When eventually women of color were shown to be overrepresented in AIDS surveillance, it reinforced this idea that communities of color sexualities were somehow perverse or exotic and categorically different than white heterosexuality. But there is sort of some racial considerations that we have to talk about when we talk about data collection and reporting too. Risk categories and identities used in the surveillance do not necessarily translate into recognizable identities or even recognized groups of women. So very few women consider themselves, for example, someone who was born in a a pattern 2 country, or, you know, what does a transfusion recipient have in common with the next transfusion recipient, that sort of things. Had the CDC examined behavior, they would have ranked intravenous drug use as the highest risk, and then receptive partners of intercourse, regardless of sex, as a secondary risk or the second risk. And so if we think about behaviors, then we no longer have to necessarily think about sex differences and sexualities and identities in the same way. We can just focus on, you know, is the partner being penetrated? Are they, you know, sharing needles? These behaviors really get at the question of transmission in ways that these artificial categories get at less specifically. And the final slide, I have no visual aid for you because women who have sex with women were virtually invisible. And that was a concern for activists. So in the CDC's case report form, any woman with AIDS who had sex with a man even once since 1978 was classified as a partner of a man. So if you had sex with 200 women in the past 5 years and one man, you were automatically heterosexual for the purposes of case reporting. That's an issue. Activist Zoe Leonard reported that the case report forms were often filled out in the patient's absence. They were often illegible or incomplete, and that the CDC found that it was impossible to categorize 700 out of 5,000 women because they couldn't determine their sexual behaviors from the report forms. This is a challenge with any sort of reporting form, but it becomes a particular problem when we are already having trouble getting data on these more vulnerable communities, and more vulnerable because in some ways they're just absent. Women who had AIDS or women with AIDS who reported having sex with women were sometimes considered to be lying, or they were accused of providing incomplete data when their case report form was being filled out. And this was their exclusion was somehow justified because there was this belief that lesbians typically had low STD rates. There was a pervasive cultural assumption that women who had sex with women have sex infrequently, and that their sex is, to quote Clay Stevens, too gentle or boring to transmit a virus. So this goes back to this passive participant in sex question that is fueling so much of some of the sex bias we're seeing in this particular data issue. So now that I've kind of talked you through some of the important historical notes and activist concerns, I want to get into the findings from my project. Most of the slides that you're going to see here are coming from archival research I did over the past couple of years in San Francisco. And so some of the images are slightly wonky. So I apologize for that, but I think they're all fairly clear and you should be able to see it. So this is an example of the very first case report form I can find in the archive. These blank forms are not easy to find, but this was one of the coolest ones I found because it had the handwriting. I don't know if this is Marcus Conant's actual handwriting or this was just kind of Xeroxed, but it was in his files. UCSF, University of California, San Francisco. So this is dated as June 1982. And this just gives you a sense of what some of the earliest case reporting forms looked like. If you look down at the first, so the far left document, the illnesses at this bottom half of the document, these illnesses corresponded to illnesses that were part of the case definition for AIDS. The case definition set the parameters for what was considered an AIDS case. This case definition had a very, very strong bias towards how AIDS appeared in gay men And we would come to learn eventually that AIDS syndromes manifest differently in different populations. So intravenous drug users have certain types of symptoms that differ from gay men. Women sometimes experience more gynecological issues or vaginal issues, and those vaginal issues actually never definition until 1992, and then it was one, and it wasn't even the most pervasive, according to sort of activist research that the women were reporting as suffering from with AIDS. So this is a two-page form, and we'll talk about this in more detail in a minute. And this is the 1985 form. So there's a difference of 3 years, and we can see this is far more formal and doing slightly different work in some interesting ways. So the first issue that I found with the case reporting forms is that they answered questions that they knew to ask. And so one of the easiest ways that we can show this is by looking at the so-called 4H groups. So in the US, there were 4 groups of people who were said to be most at risk for AIDS: homosexuals, heroin users, or later intravenous drug users, Haitians, and hemophiliacs. All right, so this was the 4H group or the 4H club, and sometimes AIDS was called the 4H disease. So we can see in this 1982 form that those are starting to be written into data collection. So obviously Haitian is not a race, but we are now going to collect data on Haitians. Right. We see on this form also the inclusion of blood transfusion before illness. So, is hemophilia a factor here? And so we're going to collect data on known sort of quantities. Not inherently bad necessarily, but there is the potential that you are not going to sort of view all the data and possible correlations if you're looking for specific things and getting the data for the things that you know to look for. Asking about sexuality instead of sexual behavior will also create sexual identity as a risk factor for AIDS instead of sex acts. So that's a complication. So instead of saying, receptive sexual partner, to say homosexual or bisexual is to imply that there is a stigma with the identity itself. And there is no indication that the CDC sought to discover why so many women would come to be categorized as other in their transmission routes. So we'll see in a minute the sort of sheer, unfathomable number of women who are just other transmission risks. No one really knows. They also claimed that the definition was too narrow. So the case definition that sort of defined who could be considered an AIDS case in the first place. Activists claim that it was too narrow and not accurate. I actually found that this was not the case. It is true for the opportunistic infections that counted for an AIDS diagnosis. However, the forms did eventually or initially include information on a person's sex, their sexual orientation, and their sexual behavior. So in a perfect world in which I had access to all of these case report forms as they were filled out, obviously this is with the caveat that they were filled out properly, we could go back and retroactively reconstruct AIDS rates in bisexual women, in women who had sex with women, that sort of thing. They wouldn't be accurate to, to a T, but they would be closer than the total lack of data we have right now. The second issue here is that the weekly surveillance reports, which I'm going to talk about in a minute, were the more significant source of sex bias. Right? So the form, as we just saw, collected data about sex, sexual orientation or sexual identity, and sexual behavior. However, that data never appeared in the surveillance report form that circulated to doctors, public health officials, the public, libraries, that sort of thing. So it was data that was lost in translation. We had it, there was a black box of decision making, and out came the report with the data, and all of this is gone. So these choices, these deflections of reality, the choice to leave out women and sort of details about women as women, that deflection was an ethical choice, and one that had impact on, women then, and continue to have an impact, as my sort of initial story illustrated, even now. So once these forms were sent to the CDC, they would, as I said, be published in these weekly surveillance reports. This is an example of an early surveillance report from 1985. These are going to give a lot of demographic data, right? Patient groups, age, race, ethnicity, primary disease. You'll note that primary disease, KS, is Kaposi sarcoma, most often found in AIDS, in gay men with AIDS. PCP was more sort of equal opportunity infection that affected a lot of people with various methods of transmission. But we still see that the primary disease, even in 1985, is sort of privileging syndromes in gay men. All right, and then there is this sort of third page. So these things start out as 2 pages, expand to 3, and then by the end of the 80s into the 90s, they become these behemoth documents that are like 20-some pages long. So I have 2 things I want to talk about here. So first, sex and sexuality. This is a talk on sort of gender bias and, gender obfuscation in epidemics, but because of the way that the CDC constructed their documents, we can't talk about one's sex without talking about their sexuality too. It's impossible. And what I want to say about this is that, let's see. So some of the earliest reporting forms were some of the most inclusive reporting forms, funnily enough. And perhaps this is because, so much was, not known about AIDS. And so they were just kind of collecting data from everywhere and seeing what kind of stuck or seemed significant. But we did see the presence of bisexual women counted in one case report form in the archive that I've found so far. And this was the sort of golden moment for me as a researcher, because I was able to, as someone who studies absences, right? I don't actually get to work with the material I want to work with. I have to work around it, right? But this moment that I'm going to talk about was my aha moment. I'm not losing my mind. This is a real thing moment. So in a July 1982 report, this is an early version of the weekly surveillance report, we see this sexual orientation list. And there's a lot of different categories for males: homosexual male, bisexual male. These were separate at this time. Heterosexual male, males of unknown sexual orientation. And then we have heterosexual females and bisexual females. And there's only one, but that one matters for the work that I'm doing. So on August, I think August 6th, so less than 3 weeks later, she's gone. The bisexual woman is gone from the data. This is, so on the top is the initial one I just showed you from June 15th. on the bottom is the August 6th, 1982 report. And she has now not only become a heterosexual female, she's just become female. And for the astute observer out there, you will realize that female is not a sexual orientation, it's a sex. So this category is just kind of nonsensical. And anytime we have an unmarked identity, we have to, assume that they're actually talking about the privileged position of heterosexuality in the case of sexual orientation. So all women at this point become heterosexual females. Let's see. By 1983, sexual orientation is removed as a reporting category, and sexualities become risk groups. So the leftmost image is June 15th of 1982, and we see sexual orientation and the category breakdown there. This is that bisexual female example. And then, a year later, suddenly this translates into a demographic group, right? A grouping to a risk group, right? So in this case, when this happens, the no apparent risk group or the unknown risk group would always remain the second or third largest transmission category for women. And this could number in the high 30% for all female AIDS cases, right? So we're just saying, I don't know how they're getting AIDS, and I'm not going to look into it anymore beyond that. So over here, by this point in time, female AIDS cases could only be heterosexual in terms of sexuality or other. And then the final point that I want to make on this is in March 1987, we get the first mention of sex work, which may seem like it took a while to come around. This is from the March 30th, 1987 weekly report. And you'll see that under this footnote 3, so this is the undetermined category up here, of which 1,044 people fall into. This undetermined category includes patients of whom risk information or on whom risk information is incomplete due to death, refusal to give information, etc. Patients still under investigation. Men reported only to have heterosexual contact with a prostitute, and then someone who no specific risk was identified. This is really curious to me as someone who's interested in sex and gender and AIDS, because if these men reported to only have had heterosexual contact with a prostitute, then why aren't they considered a heterosexual contact risk, and that's it? So there has to be something here with sex work that the CDC wants to get at. I don't know that they ever really get at it, but it is something that will continue to pop up on occasion. I have a brief thing I want to say about sex and race. This isn't the race talk per se, but it's really relevant when we're talking about intersectionality and risk. It was not until 1989 and the development of monthly reports instead of weekly reports, the transmission rates were reported for sex and race together, right? So prior to this, for example, we had no data on female Hispanic intravenous drug users. We had data on intravenous drug users and females, and we had data on Hispanic intravenous drug users, but we never could do the intersectional work that needed to be done. So it's only at this point that we can do that. And so you'll see on the left-hand side of the screen here, the way that transmission categories were set up by risk group, and then, transmission categories, and then racial and ethnic group. And the first is males and females, and the second is according to the racial ethnic group. And then in 1989, we see that finally we can go over to female as an exposure category and, find out how many Black women contracted HIV through intravenous drug use, or AIDS actually, because this might be HIV at this point in time. But generally a lot of this data was AIDS data specifically. The other issue is that a lot of racial and ethnic identities became reduced to the other or the unknown category. So this is an example of, in 1988 still, of all things. So we see a footnote here that says this other or unknown category includes patients whose race and ethnicity is Asian Pacific Islander, which is a total of 294 persons, and American Indian or Alaska Native, which is a total of 52 persons. A note here, even with COVID data, some states don't report on these particular racial or ethnic groups. It varies by state. And so this is an ongoing problem of what racial categories we make visible and those that we sort of reduce to this excess category and sort of re-other them in really problematic ways. So this is incredibly dehumanizing and disappointing. So women like Elliott and Smith in the off our backs anecdote were definitely justified in their confusion. The best case scenario, women who had sex with women or lesbians were regulated to the other or the unknown category of AIDS data. Worst case scenario, they were not, visible at all. And maybe the AIDS rates in women who had sex with women were too small to track, but insignificant risk supported by data is very different from insignificance due to the omission of data. And that's an important distinction. And bias, it didn't just affect women who had sex with women. That was just sort of the opening gambit to this talk. It affected all women. So, for instance, as I said, women of color had no data nationally reported about them until the late 1980s. And even then, the reporting wasn't particularly nuanced. So in the case of HIV/AIDS and who is made visible, it's literally the difference between a life counted and a silent death. And the silence among women was deafening. Accurate surveillance is even more critical due to the various governmental bodies that then use this surveillance data to distribute funding to AIDS education and social services, disability, like Social Security, that sort of thing. So while visibility within surveillance apparatuses for marginalized communities can be life-threatening, and I would never argue otherwise, in certain cases, it can also be life-sustaining. Thank you all for coming to the talk.